Hi, and thank you for joining our conversation today. We're so excited to be part of the Rock Health Summit virtual panel series. My name is Jennifer Yu. I'm a healthcare regulatory partner at Fenwick & West, and I'm your moderator for today's timely discussion on women's health in the post-Dobbs world. We're now about 2 months in after the U.S. Supreme Court issued its decision that overturned Roe v. Wade and ruled there is no constitutional right to abortion, leaving it to the states to take action to either ban or protect abortion rights, and creating a situation where a woman's right to health care is either fundamental or something far less, depending on which state she lives in. So post-Dobbs America is pretty sobering as we now see that the ruling has far-reaching implications beyond abortion, and what is likely clear to our viewers is that there are more questions than answers. So today, our panelists will provide expert insight on some of those questions. And specifically today, we'll talk about the impact on women's health inequities, how digital health innovations can potentially bridge the gap in reproductive care, and how the post-Dobbs world looks for employers. So before we get started, let me briefly introduce our 4 superstar panelists, and I'll do it in alphabetical order. First is Erica Seth Davies. She is CEO of RIA Ventures, a nonprofit venture whose mission is to create a vibrant U.S. market for sexual, reproductive, and maternal health, producing equitable outcomes through investments in and technical support for early and growth stage companies, driving innovation, access, equity, and reproductive and maternal health. Second, we have Dr. Michelle Goodwin. She is an award-winning author, commentator, advocate, and chancellor's professor at UC Irvine. Michelle holds appointments in law and at the School of Public Health and is the founding director of the Center for Biotechnology and Global Health Policy. Michelle, on also her free time, has published 5 books, more than 100 law review articles, book chapters, comments, and opinion editorials addressing pressing matters of law, society, and global health. Next, we have Dr. Megan Ranney, who is a practicing emergency physician, researcher, and advocate for innovative approaches to health. And she focuses her work on the intersection between digital health, violence prevention, and public health. Megan is the academic dean for the School of Public Health at Brown University and founding director of the Brown Lifespan Center for Digital Health. And lastly, we have Kate Ryder, founder and CEO of Maven Clinic, the largest virtual clinic for women's and family health, offering continuous holistic care for fertility, pregnancy, and parenting. Maven's digital programs are trusted by leading employers and health plans to reduce costs and drive better health outcomes for both parents and children. Welcome, everyone. Thank you so much for joining us today. I'm so excited about this session, so we'll get started. And panelists, I may direct a question to one of you initially, but please feel free to jump in at any time to add to the discussion. So we'll start with Michelle. So we know, Michelle, that 1 in 4 women in the U.S. have had an abortion or will have an abortion. And that's a pretty staggering statistic. But the decision will disproportionately affect women who are poor, young, and women of color. Could you give us a better understanding of the impact of Dobbs on the inequities in women's health?
I'm happy to, and thank you very much for moderating this panel. And I think before setting the stage with regard to the impact, it's worth understanding what the law actually is, because there's so much confusion that's been laid within this particular space. And I'd start with for helping to level set in terms of what Roe v. Wade was. It was a 7-2 opinion. 5 of those 7 justices were Republican appointed. Justice Blackmun, who authored the opinion in Roe v. Wade, was put on the court by Richard Nixon. George H.W. Bush, the first Bush president, famously helped to shepherd Title X through Congress. Title X provides for reproductive health care services for the poorest of Americans. So when we hear about women who are economically vulnerable having access to pap smears, having access to contraception, having access to ovarian cancer screening, cervical cancer screenings, all those things are through Title X. And when Title X received its victory, basically, Richard Nixon said it was a day to celebrate for public health. right? This understanding of what is basic health care had been the foundations for how we understood contraceptive access and abortion access. And in the wake of Dobbs, a case that came before the United States Supreme Court, brought by the state of Mississippi, there's so much to be unpacked there, and we probably don't even have enough time, even in this important conversation. But in the state of Mississippi, it has an alarming rate of maternal mortality and morbidity. The United States does. The United States ranks 55th in the world in terms of maternal mortality. And what this means is that the US falls far behind its peer nations, far behind, off the chart. But it also turns out that it falls far behind other countries, which the US wouldn't say that it's in league with. The United States maternal mortality rate hovers around that of nations where women are still publicly stoned and still publicly lashed and beaten to death. And now that's surprising for many Americans who haven't been able to sort of cut through the news cycles to really understand just how dangerous it can be to carry a pregnancy to term in the United States. But let me put it to you this way, directly responding from the United States Supreme Court in 2016 in a case called Whole Women's Health v. Hellerstedt. And in that decision, the Supreme Court, 5-3, this is just a few years ago, said that a woman is 14 times more likely to die by carrying a pregnancy to term than by having an abortion. Now, none of us like those figures. They're horrific. They really are, but we have to live with them. They're not false statistics. The Supreme Court was citing medical data from research, empirical studies that have been long done and that over and over again reaffirm these realities. And so as I get to the bulk of your question, I think it's really important to do that kind of level setting just so that we understand the health and science behind what we're actually talking about. And that we understand in the state of Mississippi, that the state that brought the challenge that led to the Dobbs decision, in that state, if you're a Black woman, you're 118 times more likely to die by carrying a pregnancy to term than by having an abortion. Already in the United States, there are disparities between who are the people that die while carrying a pregnancy to term and who are the people that survive. Well, it turns out that pregnancy care is really abysmal in the United States, largely. So across socioeconomics, we know that through Serena Williams, across celebrity status and so much more. It can be very dangerous carrying a pregnancy to term in the United States. But for Black women, it's amplified. They're 3.5 times more likely than their white counterparts to suffer from maternal mortality during or shortly thereafter pregnancy. And so as we look at the post-Dobbs landscape, there's a lot to unpack in terms of what it means in terms of health and safety. Those alarming rates of maternal mortality or maternal morbidity don't go away. They don't suddenly disappear because the Supreme Court has overturned Roe v. Wade and Planned Parenthood v. Casey. They don't go away because the Supreme Court says that we can't find within the Constitution a privacy right or anything that articulates a response to reproductive and voluntary servitude. And there's a lot that we can unpack there because the Supreme Court clearly overlooks the 13th Amendment, which abolished slavery and involuntary servitude. And in abolishing involuntary servitude and slavery, the framers of the 13th and 14th Amendment were clearly talking about Black women too. Slavery didn't just abolish the involuntary labor of Black men. It also abolished the 13th Amendment, the involuntary reproductive servitude of Black women, which was so well known about that the framers themselves of the 13th Amendment had given speeches about it, had written about it, about this horrific system of American slavery that made sexual chattel of Black girls and Black women forced to reproduce against their will. Receipts were kept about this. This was regularly, commonly written about in the New York Times, and abolitionists spent a lot of time on it. So where do we go from here? What comes next? Well, in terms of health and safety, there's a lot of work to be done, especially in the states where anti-abortion legislating has taken hold. These are very dangerous places for people to give birth. Texas has been cited as being the most dangerous place in all of the developed world for a person to be pregnant. The reality is that Texas competes with Louisiana, Mississippi, and other states as well. And finally, I'll say that the legislative backdrop is something that I'm calling a new Jane Crow. Not since the period of Jim Crow have we seen state lawmakers saying that they want to restrict who people can associate with, where they can travel, what it is that they can say. And this kind of chilling effect is something that communities that have been vulnerable because of their race in the United States know far too well. And it's worth noting that the communities that will be most affected by this happen to be the most economically vulnerable and also racially vulnerable Black and Brown women who are living in states like Texas, Alabama, Georgia, Louisiana, Mississippi, and far more. I'll cede the rest of the time to my co-panelists to help us unpack what is a really important discussion. Thank you so much, Jennifer.
Thank you, Michelle, for that. Erica, can you share your thoughts given the work that you do through ReAventures?
Sure, happy to. So at ReAventures, we are doing our best to leverage capital in this moment and through our work in venture investing, corporate engagement, and shareholder advocacy, ecosystem building, and also narrative change. And so at this particular moment, we are seeing an uptick in investor activity. Actually held our fund, RH Capital, open for an additional few months just because of the increase in interest from investors who have come to recognize at an unfortunate moment, but are starting to understand some of the statistics that Dr. Goodwin was sharing regarding maternal health, how difficult it is, how dangerous it is to actually carry a pregnancy to term. So thinking more comprehensively about women's reproductive and maternal health has led a number of investors to ReAventures at this time. We have actually seen an uptick in investments and reinvestments from some of our current LPs. And some of that's driven by interest in contraception, as well as some of the diagnostic and therapeutic innovations that are coming on the market at this time. And let's put that in context also in terms of what the VC landscape has looked like for women's health. And so investments in women's health are at an all-time high. In 2021, that accounted for about $2 billion in VC investing, but that's situated within about $80 billion that was going into general health care. And so while some may say that we are at a wonderful moment, I would argue that there's just so much more that needs to be done to ensure that women and pregnant people have access to the health care that they need. I think the other aspect of the work that's become increasingly apparent is how unprepared, quite frankly, corporate America was for this moment. We had all kinds of signals that this was coming. And for our part, we had actually released a couple of reports under our corporate engagement and shareholder advocacy program that were really trying to draw attention to the need for reproductive and maternal health care policy and healthcare coverage coming from the private sector to support what is literally half the workforce at this point. And so in an attempt to get ahead of this, we were encouraging companies to provide comprehensive coverage, to provide policies that ensure the success of women in the workforce. And that was inclusive of access to abortion care. So where we find ourselves now is the private sector being the backstop on access to abortion care, unfortunately. And I don't believe anybody is comfortable with that. Not companies that don't want to make public statements, not individual women who need to access care. And so it's just a deeply uncomfortable position. And at this point, more and more, we're having to look to different methods of pushing companies, in our case, publicly traded companies, through shareholder advocacy and organizing investors to make reproductive rights, reproductive health care, maternal health care a priority in terms of how companies think about their bottom line. So any company that's made a statement, for example, about racial justice or racial equity or gender equity and women's empowerment can't simultaneously then be making contributions to politicians that are bringing forth this legislation and or not including policies and again, healthcare coverage that actually would affirm women's health care. So It's a whole lot of contradictions that are happening right now, but we're again just trying to think about the ways that we can leverage capital at this moment to actually push for one, the innovations, the technology that could be useful at this moment and in the future. It's a long game, but also thinking about the ways in which the private sector can be leveraged generally in this moment.
Thank you for that, Erica. I do want to dive more into the digital health and the innovations that Eric was talking about, how we need to seek those solutions. But before that, I thought it'd be really important for Megan if you can kind of give us context of, what we're seeing in the medical field right now, especially in emergency care, who really kind of had to pick up the pace and the volume for not just medical issues that arisen because you're now seeing, providers who were providing abortion care, but also other care for women's health. They're closing their doors, and so hospitals having to pick that up. But we're also seeing, pretty grievous stories come out of the emergency room where, providers are having to difficulty managing all of the confusing laws and how they should approach it, fear of prosecution, fear of losing their licensure. But Megan, as a practicing ED physician, can you discuss the impact of the ruling on emergency care and how providers are navigating through it all?
Yeah, thank you, Jennifer. And thank you. It's just a joy to be on this panel with so many folks who I so deeply admire and have followed many of your careers for years. So thank you to Rock Health for putting together this great discussion group. I do wear these two or kind of almost three different hats. If I'm an emergency physician, I run a school of public health and then also run this Center for Digital Health. And so much of my work in public health and in digital health is informed by my day-to-day clinical practice. And when the Dobbs decision was leaked, there had already been movement within the emergency medicine community to expand our ability to provide basic reproductive healthcare services in the emergency department. Some simple things like removal or insertion of IUDs, some basic DNC care are things that are very much within our scope of practice. There had been discussion about how to provide first trimester abortions in an emergency department setting, things that are not typically done here in the United States by emergency care providers, but that are often done in lower middle income countries in the emergency care setting. But when Dobbs came down, we saw this huge uptick in both concern, but also willingness to address these issues. And I think it's important for us to realize, as Michelle and Erica, or Dr. Goodwin and Erica have already outlined, that Dobbs is not just about restricting access to abortion. And it isn't even just about the impact on our reproductive healthcare system. As horrific as those things are in and of themselves, it is right. And just to be clear, so to provide a statistic, of approximately 7,500 abortions that were performed in Louisiana last year, only about 160 of those would have still happened, assuming people actually still knew that they could get them underneath the new laws in Louisiana. So just to give you a sense of what a difference we're going to have in women's access to reproductive choice. But again, it's not just around that. It's also about access to contraceptive care. One of the very first papers that I ever wrote as an emergency physician was around Plan B and the fact that it is not an abortifacient. So Plan B does not cause abortions, but it is a widely held misconception that Plan B causes abortions. So contraceptive care, IUDs are potentially at risk, right? It's around pregnancy-related emergencies. Many of us have read the stories about the woman in Wisconsin who bled for more than 10 days after an incomplete miscarriage, also known medically as a threatened or incomplete abortion, because abortion is just a word for a pregnancy ending, right? It doesn't have the kind of larger impact that it does in the world. So there's those pregnancy emergencies. So there are a lot of women who are in states where abortion is now limited, who are going to be, as you acknowledged, in cases where their health is going to be put at risk as physicians try to figure out what they're allowed to do. There's an impact on treatment of other medical problems. As I speak with colleagues, not just in emergency medicine, but in other areas as well, folks in states with restrictive laws are facing challenges around whether or not they can treat women for cancer, because chemo agents can end a pregnancy. treatment for arthritis, for skin diseases ranging from psoriasis to acne, Accutane, right? You can't use if you're pregnant. And then treatments for autoimmune diseases often include medications that can be used also for medical abortions. And so there's this huge category of women's health care that is being restricted as a result of these new laws that are being put in place. And of course, there's the effect on intergenerational mobility and kind of that, what Dr. Goodwin talked about with that kind of perpetuation of systemic racism and access to healthcare for sure, but also this kind of structural and historical racism that has impacted the lives of generation after generation. Also the systemic socioeconomic disparities that we see, that we know that women who are forced to carry a pregnancy to term experience greater poverty, greater domestic abuse. Their children are more likely to experience, are less likely to then kind of rise to the next level. So there's going to be this huge intergenerational impact, which then impacts them coming into my emergency department because they're less likely to then have private or employer-sponsored insurance. They're less likely to have primary care providers. They're more likely to be victims of violence and to end up in the emergency department for those reasons as well. And then lastly, the last thing that I will mention is the tremendous fear on the part of providers. I think many of us followed the story of Dr. Caitlin Bernard, the Indiana OB-GYN who provided an abortion to a 10-year-old who had been raped. She would not be able to do that with a law that was passed in mid-August in Indiana. But there's a huge debate that many of my fellow emergency care providers are having to enter into, something that's impossible to figure out in the moment of a medical emergency as to what we are allowed to do legally. And the trouble is, we all say, well, I don't care if I lose my license, I need to do the right thing by the patient. But sometimes we don't have the ability to make that choice. I may not be able to book OR time or get the supplies that I need or get the instruments that I need in order to do the right thing for a patient, regardless of my own kind of conviction that my goal is to do the right thing. The system may not allow me to do that while they're trying to figure out those legal and ethical boundaries. So this is then going to have a huge knock-on effect for a much wider range of women's healthcare, but also people's willingness to practice medicine in those states. And I can tell you that my physician Facebook and online groups are full of folks who are looking to practice in other states because they are so worried about their ability to provide the care that they have been trained to do. Not just around actually providing abortions, but around which is critically important, but also around their ability to take safe and ethical care of the full range of folks who might be pregnant or kind of potentially be pregnant. And they just feel that they can't do that in certain states right now. So it's going to impair a larger world of healthcare access as well.
Thank you for that. Kate, at Maven Clinic, in addition to kind of advising employers and health plans on these types of programs, I understand that Maven Clinic is really kind of stepping up to help your providers, your network providers, think through the risks of kind of engaging in this type of care and all the issues that Dr. Irani kind of discussed. Could you give us a little bit more kind of insight from your perspective?
Well, just echoing what everybody has said, it's an honor to be here, and with Michelle, Megan, and Erica, thank you so much, and really also a huge fan of all your work. What Maven is, is we are the largest women's and family health virtual clinic, and we work with employers and health plans on fertility, which is also impacted by some of this, maternity care and pediatrics. And we do have the largest telemedicine network in women's and family health. So we work with a lot of women's health providers. Starting with the provider side, echoing some of what Megan, Dr. Rainey has said, one of the, I think, most alarming things that we're seeing is with 50% of US counties that don't have an OB already. So there's huge maternity care deserts that, particularly when we work with the plans, they're really interested in telemedicine to solve for. That's in those maternity care deserts are also in a lot of these states which are restricting the abortion access. And so as providers are thinking about moving out of some of these states, it's going to just continue to exacerbate some of this supply shortage that is happening in women's health across the US. So that is definitely something that is happening a lot. And I think, again, echoing everything that Dr. Ani said, that providers, I think, are really confused as to what they can do, and continue to be put in these impossible situations where they may not have the resources, they may not be able to actually give the care to the patient that they need. We do have a lot of care advocates working on our platform who are not, they're not providing the care, they're providing the advice and guidance and navigation. And what we're also hearing from them on the front lines is it's not just, women and families who are concerned about an actual pregnancy itself, but it's all of prenatal care. And so if you're in the phase of your life where you're thinking about starting a family in one of these states, it's really confusing because, as Dr. Annie was saying, this is a restriction to all of women's healthcare that's broader than just that moment if you have to make a choice as to what the best course of action is for you around your pregnancy. On the employer side and the health plan side, so Maven partnered with Accenture about 6 months ago. So right when SB 8 was passed in Texas, when it was pretty clear that this was happening, we surveyed a lot of employers to understand what they were going to do about it. And I think what we found is that, given that so much has happened over the past few years with the pandemic, with employers making statements, I think, as Erica said, on racial equity, on gender equity, a lot of employers just kind of didn't know, what to do. And they had so many other things going on, return to office, childcare, burnt out employees, mental health issues. It was a little bit of a wait and see. But then the day that the decision was passed down on a Friday, I would say that we saw a massive movement of everybody now stepping up to do something. And so, that old saying, it takes a crisis to act, I think in some cases it certainly applied here. But one of the most encouraging things is that people did step up. And even today, our sales team can't get on the phone fast enough in some cases, because we've seen just an explosion in interest. So we have Maven Wallet, which is a platform that supports employers offering travel reimbursement. So we do support that across state lines. And so whereas some employers are doing that through their health plans, if they don't get that through their health plan, they can do that through Maven. We also provide pregnancy options counseling as a core part of our maternity program. So, that's something that's part of prenatal care, where, when somebody gets pregnant, they have 3 options. They can continue with the pregnancy, they can think about putting the baby up for adoption, or they can terminate the pregnancy. I mean, according to ACOG, that is the guidance that, a patient is getting from their physician. And so, in states where it's harder to get that guidance, our care advocates from other states can be helping members understand their options. We're always in compliance with the law, but certainly a care advocate in a state like New York can be still giving that guidance. And so, we have seen, from big jumbo employers to small businesses, a lot of people jumping up. Now, that's not enough. We are still in the first few months, but there's still a long way to go, because I think both, as Michelle and Erica and Dr. Ani all highlighted, nearly 50% of babies are born to Medicaid on Medicaid plans. And so what that means is, and many abortions are sought out by women who are on Medicaid, who already have significant social needs. And this is just yet another burden on them that is going to, further exacerbate the inequality gap and just really, really hurt a lot of those communities, a lot of those families. And so I think we have not seen the movement yet on the Medicaid side to offer some of the travel reimbursement or offer some of this, but we're hopeful that that will come, because it's many of the individuals there are really going to get hurt the most.
Thank you, Kate. And I think it is true that private companies are stepping up with funds. And I also recently learned that there is a movement now to try to pass some legislation for a national network where states and private companies can partner to set up funds to kind of really help these women access funding, travel reimbursement, and providers, and just advice. So I think that just, it just really shows the passion and drive, and what, Erica mentioned and Kate, you mentioned too, people and companies, employers really stepping up to take a stand here. But thank you for that. Kind of a slight redirect, because I did want to talk a bit more on the digital health side. And so I think, Megan, kind of wearing your researcher hat, moving from the ED physician to the researcher hat on, digital health, can we viably, see something as a potential solution to bridge this gap, even bigger gap created in reproductive and women's health that the Dobbs decision has, pretty much breached in healthcare? From your perspective, could you, kind of give us your thoughts on the digital health side?
So this is an easy one to me. The quick answer is yes. I mean, I think that all of us are here partly because we deeply believe in the very best versions of digital health, right? So that in its best incarnation, digital health can provide access to evidence-based healthcare in a way that is accessible regardless of level of insurance, geography, ability to have transportation, language, preferred first language, cultural beliefs. It can be provided in a way that is non-stigmatizing and so preserves privacy. And it can be provided in a way that allows options that wouldn't otherwise be available in a community, right? That's the version of digital health that I think many of us have subscribed onto, is that it provides greater access to high quality healthcare for a greater number of people. And it obviates many of the existing causes of inequity in our healthcare system here in the United States, as well as across the globe. That's the vision. And I think it's absolutely possible. And I've seen examples of it where it's been done well. And I actually think we've seen a movement towards it, as many of you, and I think Kate and Eric in particular, have already alluded to. In the post-Dobbs world, I have seen many so-called femtech or women's health companies actually step up to a degree that they hadn't before, with the pressure of outside experts, to now ensure that it's being provided in a way that preserves privacy and maximizes security and maximizes ethics and maximizes access to folks that, that it's not just for kind of the people with employer sponsored insurance or the folks that are able to pay out of pocket. I'm going to give one example of one source of digital reproductive healthcare that I just love, founded by, or kind of recently led by one of our medical students at Brown, who's also a VP at Bessemer Ventures, a guy named Morgan Cheatham, helped to run a company called Folks, which actually provides care for people who self-identify in the LGBTQ plus community, and has seen kind of an increase in usage and is thinking about ways to expand in this kind of post-Dobbs world, right? To provide access to folks who are people who may be pregnant, right? Who are kind of in that space where it may not identify as women. And so I think there's a lot of spaces where we're seeing people move into that they hadn't been in before. Another example is, right, Flow, which had been the subject to a expose around their privacy practices with data, has actually tightened its privacy practices post-Dobbs, which is so necessary. And one of the things that I talk about a lot in digital health in general is around that ethical obligation to our patients. Most digital health companies, right, are not subject to HIPAA. And there's been study after study showing that many digital health programs don't follow basic evidence-based guidelines, sell data without permission, or share data with third parties without permission, right? Not all, and I know Kate will talk about what Maven does, but so not all, but a lot, unfortunately, did not follow best practices because they weren't legally required to. And we've seen, with this increased pressure, we've seen a lot of companies step up in ways that they hadn't before. So I think this may actually drive a golden age for high quality digital health for reproductive health care. That would be my hope. That's the optimistic version. We could also go down a pessimistic kind of horrible view of what comes next. I'm sure Dr. Goodwin can give us some insights onto that from her legal perspective.
Dr. Goodwin, could you actually talk about that piece? I think that would be really interesting to kind of get your opinion on that.
Well, I really appreciate the conversation that we're having, because these are truly alarming times. And to level set a bit, we're in the unimaginable space, what many people have said. I have colleagues who study this field as much as I have. I've spent 25 years working in this space, and I have colleagues who have spent time exploring the history of reproductive health rights, justice, and so much more, who were alarmed and surprised by the Dobbs decision. I wasn't. And that is perhaps in part because what I study as well, and what I've been keen to investigate in the wake of all of this are systems and histories of American enslavement, the subordination of women, Jim Crow, all of that. And if we take those times seriously, then we know just how terrible it can be and how terrible it can get. A scholar who comes to mind who was so profound, and I'd love to place her, them in this conversation, and that is Pauli Murray. So Pauli Murray wrote what Thurgood Marshall described as the Bible of the Civil Rights Movement. And that's on racial justice. She actually, while she was in law school, her second year of law school, wrote a paper that became central to the litigation that was done in Brown v. Board of Education. But she also was the predecessor of Ruth Bader Ginsburg at the ACLU by decades. And in 1945, wrote an article about how to eliminate sex inequality in the United States. I mean, she was absolutely amazing, and she's Black. And I think partially because, or significantly because of her race, so many people don't know about this incredible legal mind and agent who was so central to dismantling racially unjust laws and unjust laws with regard to sex. But she wrote this book on race laws in America, and it's about 800 pages, single space, and it delineates just the lengths to which lawmakers would go to oppress Black people's ability to be able to be free in their minds and bodies. I mean, just ridiculous laws. Black people can't play checkers in the park. Black people can't swim in the pool. Black people can't play billiards. They can't play, bowl. I mean, you think really lawmakers spent their time creating laws saying that Black people may not bowl? Like, really, wasn't there more for you to be able to do to help promote people, right? And I think it's important for this conversation to understand that if it could be that incredible, that depraved, that sort of fundamentally depraved, it can be that too within these spaces. And we're already beginning to see that. When a 10-year-old girl has to flee the state of Ohio to get to Indiana in order to be able to terminate a pregnancy after rape, and you have lawmakers claiming that it's a hoax. Why hoax, especially when their laws specifically anticipated the 10-year-old girls, and that they specifically decided that the 10, 11, 9-year-old girls would not have a remedy in their states to be able to terminate a pregnancy. And then later on, they said, oh, well, this would have been able to, a pregnancy termination would have been able to happen in the state, despite the fact that the laws that they explicitly wrote, interpreted by the nonpartisan legislative bodies in their states, say there's no room in these pieces of legislation that would have provided any kind of relief or remedy for this 10-year-old girl. And we see across the country lawmakers suggesting that they'll ban people being able to use the word abortion if it's used to be able to help people search in libraries. We see it when, in the case that Dr. Rainey spoke about, a woman bleeding for more than 10 days with an incomplete miscarriage in Wisconsin, where doctors feared exactly what it was that they should be able to do, fearing the possible prosecution of them and losing their licenses to practice medicine if they provided the kind of medical care and support that they would have just the day before the Dobbs decision. We have lawmakers in this country that are threatening fundamental protections in terms of the right to travel, which even preceded the Constitution that we have now. So important was the right to travel, but the threat is that women may not leave, women, girls, and people with the capacity for pregnancy may not leave their home states in order to be able to terminate a pregnancy elsewhere. There are lawmakers that are threatening to be able to prosecute doctors in what I call free states like California, Illinois, New York, Colorado, et cetera, and extradite them back to their home state. I mean, it is the manner of really what some people would euphemistically call the wild, wild west. It is an area that is absolutely unmoored and unhinged from civil liberties and civil rights and what we knew just the day before Dobbs.
I just wanted to actually extend that then to the responsibility of digital health companies to protect privacy. So, and I'm sure Dr. Goodwin has a much longer and deeper history to explain on this, but then who gets criminalized when this information is weaponized? And so not only is the privacy important, and it's our position even at RIA that these companies actually do need to understand this history, that there is a necessity to understand how reproductive oppression has operated in this country. So in this moment that folks thought couldn't happen, but has been happening for centuries to Black women, to immigrant women, to women of color, to poor women, women who are experiencing poverty, that there are ways in which this moment will actually, and we talked about worsening in terms of access to care, but I would even suggest worsening the tendency, again, to criminalize certain groups as opposed to others. And so while we're in this data gathering moment, this opportunity, this potential, I won't call it a renaissance, but this potential opportunity for digital health to actually be a problem-solving agent, it could also create more problems than were originally anticipated. And so it is incredibly important that people actually have that context as these different products are coming to market, as these innovations are being developed and coming to market. I appreciate platforms like Rock Health for actually creating an opportunity to have that conversation, but it needs to be much more prominent, because I worry about what will result from this if that is not part of a strategy, right? Like if that is not part of a go-to market strategy, understanding who is in that market and how that those women and pregnant people and people who could become pregnant have been harmed in the past. And so I just wanted to.
I would like to build really quickly on that too, really, really quickly, to just say that Dobbs does not resolve the histories of racial surveillance and racial profiling in our country. It doesn't, right? So empirical studies that have been done by the Department of Justice, right, done by scholars, all show us disparities with regard to the enforcement of civil laws against people of color, criminal laws against people of color, disparately for the same things that white people may do. You find, for example, studies back in the 1980s and 90s with Black women being criminally punished for conduct, related to their pregnancies, and then civil punishments as well, which can exist in relation to their pregnancies. And what that data showed is that Black women could do the exact same things that white women did and were 10 times more likely to be reported than white women were. And so as we sort of think about these issues in modern time, that doesn't go away after Dobbs. So Dobbs is not a balm for racism and racial inequality in the United States. Instead, what it does is it creates a platform that now allows states to go even more aggressively in their past conduct, bringing that now in a post-Dobbs reality. So we will likely see the amplification of surveillance and punishment that will be disproportionately placed upon Black and brown women in the United States. And that's just logical and reasonable based on everything that we know.
Can I just one quick sentence is just that I think that one of the things that I just want to underline about what both Erica and Dr. Goodwin said is the importance of funders and VCs to think about this as they're choosing who to fund, to make sure that those privacy standards are not only up to snuff, but above and beyond, that they are kind of meeting, they're taking into account the historical legacy, but I think it's on the funders yes, it's on the founders, but we need the people who are deciding what to fund to take this into account as they're making choices.
Thank you. Thank you for that. So we're almost out of time, but I did want to have each panelist give us very briefly their input for one last question. From your unique kind of personal perspective, what is one practical way individuals or businesses can support reproductive care and awareness that women's health is healthcare? It's not something novel, it's not something new, but it's healthcare.
I can start. Vote.
I'll just add to that. Be careful about where they place their resources when they're giving to candidates. You can't on one hand say, well, fly, women out of town to get the reproductive health care services that they need, and at the same time back candidates that not only will restrict rights to abortion and contraception, but candidates as well that have been addicted to voter suppression, that will not allow women to be able to exercise their vote, exercise their right to be able to vote. So these issues can't be seen in silos. They must be connected together. So it's voting and making sure that their resources go to candidates that support the rule of law, that support democracy, and that support women's fundamental equality rights.
To me, it's really about understanding that you cannot have women's health or people's health without reproductive health. And understanding that when our reproductive health is impinged, so is every other part of our health. And as we've seen during COVID, when health gets impaired, so does our economic success and security.
Everybody's covered the ones that I would say, but I would also say if supporting organizations, support some of the framework, the network of abortion funds right now, just to ensure that there's immediate access to care, but also support the reproductive justice organizations that have been on the ground for years, trying to move this agenda at the state level, but also tackling the issues of voter suppression, also tackling the issues around civil rights. And so I think those are the two ways that I would suggest individuals or corporations leverage their, at least their philanthropic resources at this time.
Thank you. Kate?
Oh yeah, I think I started it by saying vote, and I think what happened in Kansas is a great example of how a lot of people actually feel.
Awesome. Thank you so much. So we'll end it there. That was an amazing session. A huge thank you to our amazing panelists, Michelle, Megan, Erica, Kate, for your time and participation on today's virtual panel. Thank you to Rock Health for putting together this session and hosting us. And thank you to our viewers. I would say let's continue to talk and share and keep these important issues in the forefront. So thanks again, everyone. Bye.